Okay, let me introduce Dr. Josephine Etowa. There are some news I can share with you, and there are some news I cannot share. Dr. Etowa is a full professor in the School of Nursing here at the University of Ottawa. She's the scientific director of the Interdisciplinary Center for Black Health. In June, she launched the Black Women Health Initiative, and I really think Black women mental health is an important issue, a very, very important one. And I really think we as Black men, maybe we are part of the problem. Not just maybe. Thank you. And some news to do not share is the fact that in some weeks and months, I hope weeks, the government will announce that she will be the person dedicated to work on Black women health for the next 14 years. And I'm really happy to have her with us today. Ladies and gentlemen, Dr. Josephine Etowa.
Can you hear me? Okay, great. And so, we need to talk about resilience, but at what cost, but also moving it to community resilience, the collective resilience. And that's what we saw during the COVID-19 pandemic. I see what the problem is. No, what? Okay, so let me see. Oh, I see. Oh. You know what? We just. So the context, because before we talk about resilience, why is this so important in our community as ACB people, African, Caribbean, and Black? And I like to use that concept of ACB because it constantly reminds me that I cannot leave anyone behind. When we're doing research and working with communities, we must remember Black Africans, we must remember Black Caribbean people, we must remember Black people that have lived in the Western world for multiple generations, whether it's in Canada, in the UK, in the US. How do we capture the nuances that differentiate the experiences we have as Black people from these different contexts? And so it's important to highlight those differences. And we know that in that heterogeneous community called Black community, Black Canadians, that there are multiple historic and these present day factors that have created a condition within which we are rendered vulnerable. And I say rendered vulnerable because it is not that we're born vulnerable. It is the circumstances we find ourselves in that renders us vulnerable to both physical and mental health problems. And I'm not going to get into so much of what our speakers yesterday covered so well in terms of the many conditions that disproportionately impact us as Black people more than other communities. Those conditions we talked about yesterday by Dr. Williams from the US, we're finding similar results in the Canadian study. Judy's done a number of studies looking at mental health, looking at whether you talk about COVID and, well, we saw COVID and we saw what happened. I've done a number of studies and we continue to see these issues. And so we know that even though we have universal healthcare system in Canada, we still have those inequities. Over the last 4 years, I held a research chair in Black women's health, in Black women's HIV prevention and care, funded by the Ontario HIV Treatment Network. And I would say, just looking even on HIV, many of you have heard me talk about this before. Over the last 10 years, we as Black people have consistently carried about 25% of the burden of HIV in Canada. New diagnosis. Black women are significantly higher, over 50% of new diagnoses. Black women of those that are, yes. And then actually getting tested and getting diagnosis is also a problem in the Black community. We don't want to talk about it. The stigma is so much, and so we don't get tested. And so even with the UN target of reaching 90, 90, 90, and now they've moved it to 95, 95, we're still in our community, we're not even meeting the first 95. That is 95% of people who know their HIV status, 95% of those who know their status would be on treatment. And 95% of those who are on treatment will have viral load suppression so that they will not be able to transmit the virus. U equals U. Undetectable equals untransmittable. But we're not even meeting those targets. And so it's great that the federal government has increased this decade of people of African descent in Canada by about 3 years. Hopefully we'll make progress because, as I've said, people would move on and say they've treated HIV, it's no longer a problem because they've reached 95%. But that 5% could be Black people because, we make up about 4.5% of the Canadian population. Yet we make up 25% of those living with HIV. And so that's one example, but we can mention others: cancer, diabetes, and the list goes on, prostate cancer in Black men. And so when you look at all of these factors, we go back to this whole idea of anti-Black racism. As a root cause that affects us, whether it's through housing, criminal justice, you just talked about it so well, public health, education, banking, it impacts us in so many ways that just compounds the issues. And so then when we go to the healthcare system, we also are faced with providers who have the bias, the lack of cultural competence, the lack of anti-racism work. Yes, now we have EDI policies and we have anti-racism policies. It's interesting because I'm hoping the next project I want to engage is to see how that is actually working in terms of changing the structural barriers to these issues. The processes in place, how is that leading to more Black people being in leadership roles and succeeding and getting the resources they need to do it well, not just to be in those roles. So how ACB people live and maintain well-being while dealing with the burden of racism, and how the social determinants of health combine to amplify systemic threats to their health continues to render them vulnerable in terms of both physical and mental health. And so when we're talking about our health, we need to use multiple strategies that must include addressing racism. Racism remains a major problem at the root of these inequities and call for multiple interventions. So multi-pronged approach, including how we conduct research, and that's the area I'm focusing on. The theoretical frameworks that guide the research and the program development we do in our communities. We have to engage in interventions that not only face the community but also face the system. What are they doing? If we build capacity and we're resilient in the community, and we go to a system that still shuts the door and the windows of opportunities on us, how do we get there? And so we must do that intervention in both ways, system-facing and community-facing. So the example I'm giving today is some of what we're doing here at the University of Ottawa to face the community and prepare the community to engage with the system and ask questions. So targeted interventions, of course, needs to tackle the 5 P's there: the purpose, why, what's the intention? behind even some of these policies and the programming that we're doing. What's the process? Who are the people involved in all phases of that process? And where's their place? Which places are we focusing on? And we must look at power dynamics too, because power plays a key role in terms of dismantling the structural piece that we're talking about. And so linking, you can see here, I like this, and I got this from one of, I don't even remember this reference, but I have my reference list, so I can always send you. But it's a recent article that really links this racism to, if we're looking at policy, looking at well-being, we have to constantly go back to this root piece. You can see whether it's social factors, whether it's psychological factors, or the biological factors that we see. All of these are linked to racism. And all our interventions must come together to address all of those pieces. So in terms of research, giving this context, when I engage in research with Black people, I always think about how exactly are we going to do this research in a way that is respectful. So ACB research is motivated by values that promote respectful, equitable, diverse, inclusive, and meaningful engagement of the community. How can the community inform what I go out there to do? And so right from the time I think about the research question, my next step is talk to some community members. I'll give you one example of a study we did in 3 countries looking at infant feeding practices of Black women living with HIV. The study involved Canada, so Ottawa in Canada, Miami in the US, and Nigeria, and Port Harcourt in Nigeria. And it started by just a question, which actually came from a community member. We were just at the airport returning from HIV conference, and it's like, there's a problem in our community. I think there are people who are closet breastfeeding. I think there are issues going on. He said, really, how significant is this problem? He said, I think you really need to do a study about this. Okay, I go home, do a quick search, do some quick literature review, call a meeting with the community. And of course, some of my colleagues from the university. And we have a focus group to present what I was seeing in the literature about the topic, and to ask the community, is this a problem in Ottawa? Is this a problem we should be addressing? We broke up into a focus group or breakout rooms, and they came up and there was a pattern. That is definitely a big problem in terms of how women, the stigma in the community, they need to be good mothers. It's affecting women's ability to say, I'm not going to breastfeed my baby because I'm living with HIV. But at the same time, the fear of their public health practitioners and the criminalization associated with that makes them to closet breastfeed. So they see their mother-in-law and other people, they're going to breastfeed. But when they see their healthcare providers, they say they are formula feeding. And that was how that study was born, based on this kind of approach. And we did this. Today, I can't share much results with you because I have 25 minutes or 20 minutes now. Okay. So these values call for the use of critical and empowerment theories, theoretical frameworks such as socio-ecological model that Dr. Lashley spoke about, intersectionality theory. These are standard theoretical frameworks that inform every project I engage in. So the integration of theories like this really facilitate the discovery of layered forces of oppression that you've talked about, that can be at play in any given situation, whether it's around the issue of race, ethnicity in terms of our various social locations as people of African descent, gender, migration, class, in addition to the specific diseases. So you're dealing with a particular physiological change or disease, but you have to situate that within your own social location and every other thing you're doing. And we need approaches that can allow us each time to get at those issues from different angles. And that's what some of these theories do. It also, dealing with this also means using more of a creative approach that allows you to create change as we go. We don't have time to just produce knowledge, publish it, and hope that somebody will pick it up and do intervention. Thank you. We must create the change as we go. That's where transformative engagement processes such as community-based participatory action research helps us to change people as we go. And I'm telling you, I've seen people change, whether they are working as research coordinators in the lab, or whether they are students that are in classes, or other researchers from the community. I have seen change happen. I remember in Nova Scotia starting a study, a CIHR study, that was looking at Black women across the province of Nova Scotia. Before we finished that study, some of our research coordinators wanted to contest for an election in their community. Even here in Ottawa, one of my research assistants in the lab has run for councillor a couple of times now, and she's going higher and higher. And because after you've lived through this and seen the research for yourself and lived through this process, it's like, I have to be part of the change. I just can't wait. And when you see the work that this does in terms of building not just the individual resilience, but the community resilience, because then you begin to think about community stewardship. What are the charters, the teams, or the terms that guide how you do work with community members? How can we ensure that community stewardship is at the center of even the research we get or we're conducting? Because you need that stewardship to continue to use that data. Most of the time when we do research and the community does not have that research to do their own strategic planning, because we house this research in places that they may partner with us and provide this data, but once the data is collected, how do we give it to them? We're beginning to use strategies like data visualization dashboard. The last study we did with COVID-19 impact across the country, we created a data visualization dashboard where you can actually go in and pick some variables that are important to your work and use it to, and actually do the analysis live there and actually use it to influence maybe your strategic planning and other things. So community stewardship is so important. As we talk about EDI, knowledge mobilization, and the capacity building is a key part of every project. How do we build a community capacity to continue to advocate for themselves and to use the data we're generating to advocate for the changes that are needed? And so the socio-ecological model really helps us to peel down that layers every time we go out, whether we're doing quantitative surveys or doing qualitative research. How can we make sure we're asking questions that touch on the individual level, interpersonal level, the community or institutional and organizational level, but also the larger systemic and policy level? These frameworks help us to make sure we ask questions and analyze data in ways that get to that. And then when we talk about the community engagement in terms of community-based action, it's really about starting from beginning. And this is the process I just explained to you. For this particular study, you can see here, right from when the community approaches us, community is at the center. The university comes in from above there. Do we have the... okay. I have my warning. So you can see that every part of the process community is at the center. And after we collect data, you see where we have the little World Cafe here. We're just looking for the pointer to see if I can put. That's the university here. We have our World Cafe here when we take the data back to the community before we begin to generate the knowledge mobilization tools that would continue to be produced in collaboration with the community. And then the intersectionality lens that constantly help us to see how the different social locations that we're in intersect to further compound the issues. And we have to analyze using that. Okay. So CBPR, why is this so important? Just give me the 5 minutes to speak about this point. CBPR is not only an approach to an investigation, it is a means of mobilizing for collective social action to address community needs and for creating change. So if there's one message you take home from this particular piece is that when you engage in this kind of research, you're going in to do 3 things: to educate, to collect data, which is the investigation itself, and to mobilize for social change. Something has to happen in the process of engaging in this work. And so central to this work is that the work of Paulo Freire, the educator from Brazil who published The Pedagogy of the Oppressed. So in his work, the idea is that we all have a responsibility to produce reality and to transform reality. So again, when we talk about joy, is that we have a responsibility to reclaim joy. We have a responsibility to create our narrative. And so when we see a situation that is affecting us or others, we have to analyze that situation, including its root cause, and then we have to act to change the situation, including our perception and how it then leads to how it impacts on us. And so that transformative change that happens in research, whether it's just like the example I gave of presentation, sometimes it's as you're developing the proposal and you're doing presentations about what you're finding in the literature, it becomes an educational tool for your research staff, for the community members who are attending that. And you begin to see as people get excited about the process. Okay, we'll do it this way. Okay, we'll do this way. And as you move forward, you see transformation and shared ownership. That's the other piece. And shared ownership of the data. And so how do we put mechanisms such as whether advisory committee, collaborators, and the use of mechanisms, various mechanisms that serves as levers for that constant connection with the community to ensure that even for us, for me as an academic, when I'm doing work, I constantly have to check with community. Am I staying in target? What can we do differently to ensure that this data is meaningful to you as well, that you can use it to create the change you need? And so I have talked about this co-leadership with the community is so important. And the process doesn't end. The goal of this process is that we involve community, we walk them through the steps of involving them in decision-making, involving them in terms of the whole process, whether it's through advisory or training program, but also moving on till you get to the end goal when community is empowered enough, has the capacity to initiate programs, and they begin to invite you to that program. You're now invited. And that's when we think that we have accomplished the final goal. I have a few examples of studies we've done here that constantly point to these cross-cutting themes, some of which you can see here, number 5, their resilience is a key theme that has come up in a number of our projects. The AC study had a theme on community resilience. Our COVID impact across the country is a national study, had a theme on resilience. And our vaccine uptake study here in Ottawa had a theme around resilient agency. I don't have enough time to give you all their quotation. I like to share their voices, but let me share this from. Okay, which one? Okay. Okay. So the theme of resilience, I just want to read the quote here because I want to at least have a voice from the community in this presentation. So this is the local voice here in Ottawa. I say, this is an African reality, and I believe that we have knowledge that Westerners unfortunately do not have. But as they are the ones who have the infused science, they always tend to simply ignore it. Then I believe that medicine and research would have a lot to gain by getting closer to our tradition, which builds on what you talked about. People talked a lot about just letting the people in the community bring their full self to contribute to the strategies ahead. Because some of these things, we have ideas. Black people have survived in the Western countries for generations. It is that agency that led to that survival. And I think we need to build on that and help and mobilize that so we can learn and use those as resources to build. So he's shaking his head. He doesn't know what to do with me. Jude, I just want to give one example. The peer equity navigation is one program we're using to train people right here at home in Ottawa to be those change agents that go into our community and actually begin to mobilize people to be more aware of their health needs, of their health issues, so they can be part of the change that we need to see. You go to the hospital and your needs are not being met. They need to know the resources so they can know who to report, who to talk to about how their needs are not being met. And we need to have those community organizations that can become that voice to mobilize this group of people that are trained. What we're doing at the Co-Create Lab, which is an active part of the Interdisciplinary Center for Black Health, is to literally train these people using a curriculum that really centers on understanding the history of Black Canadians, moving on to understand how social determinants of health and racism plays a key role, and using the whole idea of critical health and racial literacy program to educate people to create that change, even in the peer educators before they go out. So that's where our, I can't even talk about, these are the community, these are the peer equity navigators at work here in Ottawa. They go to where they will meet Black people, whether it's in their homes, in the mall, peer equity navigators. And actually the foot soldiers at work was a nickname they called them in the community, the peer equity navigators going. They made this uniform for themselves. We didn't give them uniform and we saw them. They actually went and designed their own T-shirt. We are the pairs that will rewrite the story of health inequity in ACB community. So they're rewriting that. We've done some evaluation. We're just getting that. That's been submitted for publication. And again, they speak very highly in terms of what the training does to prepare them and what their work in the community does as they go to talk with people. Somebody say, I think we had a very big and strong impact on the community because as peers, we are not like scientists or decision makers in health. We are more like shoulders for many community members to rely on for the right information. And we, as researchers, are there to give them the evidence that they can take out. I'll stop. I followed my sister's footsteps.
I'm sorry, I have the bad rule. I have the bad rule. If you have questions, we still have 5 minutes for questions. We have a question here and another one here.
Yeah, sure.
Thank you. That was brilliant. It was fast and brilliant. One thing, can I see just the slide before this one, the conclusion? And then the other thing is, when you are training the peer researchers, you're giving information. How do you make sure? So I'm working from a community perspective. How do we make sure that that when they escalate into the system absorbs also, like the health system also absorbs? How do you make these connections so that if people do actually seek the help that they need, that they actually get it?
So good question. So the peer equity navigators are meant to be community facing. Their job is make sure Black community understand their health needs and that they can ask the right question when they go there, that they get the help they need. So we give them the evidence in terms of the different issues. If it's vaccine, that's our focus. We're actually training across Ontario right now. We've got a 5-year CIHR grant to train them across Ontario to deal with HIV among Black women in Ontario. So watch out, we'll be hiring in December and start training in January for PENS across Ontario. And so we're training them, but they're also affiliated with frontline organizations. So Ottawa Public Health, for example, is one of our preceptors. The training finishes with a practicum option where they are paired with a preceptor that would now show them the local resources. They do community events with the local resources. Our goal is that eventually, because they work so closely with the community, with the service providers, those service providers would see the relevance of working with such people, and hopefully they can be absorbed into the system, we hope. We're also working on a national study that also has PENS. But right now, we don't have them hired into organizations. Research grant pays them while they are doing this work. Yeah. But for the most part, we've seen some of them hired. Yeah.
Another question here.
Okay.
Can you hear me? Okay. Thank you so much for that presentation. That was really good. I want to zoom out for a moment because you talked about checking with community, and I'm thinking about it in terms of policy, right? So there's policy development, and then there's policy implementation, but then there's policy iteration. So what is the mechanism you think is best when thinking to check, like, between the implementation component of it and then the iteration of it, especially when you're working like within the system? I think I'm just thinking in terms of, I know you're specifically talking about, HIV and whatnot, but I was thinking about just health as like, as sort of like a bigger entity, and like when you are checking in when you create policies, and then you have like, but what is the mechanism that you think is best when you check in after you implement it, right? Because you have to see if it works first. Yeah.
Alternate. For checking that the policy works, still have to come back to community. So when we create policy, community should be part of that policy creation. From beginning, they should inform that policy, because when you don't do that, then sometimes this policy does not truly meet the needs of the community. But we should have mechanisms in place to also monitor those. That's what I'm saying, that we do need more research, and thank God CIHR has a call. The Canadian Institute of Health Research has a call that just closed on October 9th, looking at structural determinants. So we can finally at least do evaluation research to see how are all these anti-racism and EDI policies working, even in the organizations that use, and look at processes.
Thank you. Thank you.
Thank you for the presentation. I attended this conference 2 years ago, and it was great. And your slide is the first time I've ever seen banking mentioned, I believe. So what is the impact of banking on Black mental health?
They can hear me.
Like to have a question.
Okay, please go ahead.
Josephine, thank you very much for that amazing work, really engaging communities to do research. And I guess really you're tapping into a very important cohort, which is community engagement people. And oftentimes with these amazing programs is that obviously they are funded upfront. And then when grants end, what tends to happen is that these community or workers then tend to then either get disappearing off and stuff like that. I'm just curious as to thinking about really the amazing work that Penn and others you're building up. What's the future to ensure that these pieces of work are scalable and sustainable? Because there's often times when budgets get cut off, these are the first groups to disappear. Thank you.
Right. And that's why we have, even from the design of the PENS program, they're all affiliated to organizations, like I said. So in Ontario, we'll have organizations that they are affiliated to. It's similar to the model that they've used for the HIV strategy worker for Black community across Ontario. The actual group has been implementing HIV strategy worker for more than 10 years now. And so we're hoping that they can be employed in the future. Right now, we don't have that funding yet. The strategy work I'm talking about is a standard budget from Ontario Long-Term Ministry of Health to fund that initiative. And they have the council, actual council, the African Caribbean Council on HIV in Ontario. Yeah. So we're still working on that. I hear your two questions. We do need sustainability plan to keep PENS because we know it works. When I met, and I think it was Councillor King that was speaking at one time, he said, we need people to meet Black people where they are. Go to the salon, go where they are. I said, PENS are doing that. We just need money to keep that role. Because, yeah, thank you.
Dr. Josephine Etowa,